Our digital education series is brought to you by our 2022 education sponsors. Special thanks to our presenting sponsor, Merck, as well as our supporting sponsor, Exact Science. And we cannot do it without them. So just give them a little shout out there as we let a couple more of our friends in this evening. All of you feel pretty familiar with Zoom, but if you're not, please feel free to use the chat. We'll help you out if you have any questions. The chat button is down at the bottom. Please keep yourselves muted. We do have all controls, so we can mute you if we hear your dog in the background or, any of your loved ones.
Wouldn't be the first time.
Wouldn't be the first time. It may be my dog in the background, but just to allow our speakers to have front and center and no outside distractions. We will have time for a Q&A at the end, but I'll tell you, we're so conversational. And, if we feel like the answer is going to be, or the question is going to be answered within, because we've prepped the presenters, we know what they're presenting on, we'll probably hold off on your question because we know it's going to get answered. If we feel like, that's a good one, let's do it right now, Erin and I will chime in. So please feel free to use that chat as often as you need to. Beautiful. All right, Erin, I feel like I'm going to let you put us back into gallery mode. And just as an introduction, my name is Sue Weldon. For those of you who don't know me, I am the CEO and founder of Unite for Her. I am one of your MCs tonight. And then I have my wonderful partner, Erin Pellegrin. She is our senior registered dietitian manager and has been with Unite for Her for 8 years and has been doing this series. So she is no stranger to you guys. And we'll be your hosts for tonight. And, very conversational, like I said. And Erin, I'm going to let you take it from here on some future reminders.
Yeah, absolutely. So we are very excited and thankful to our sponsors for helping us support all our educational series that we do. So not just our speaker series, but of course we have our Ask the Experts. We even have our virtual hangouts. So I always like to share, just for everyone to be on the lookout. Every month we have a speaker series. So our next speaker series, which they take place the first Thursday of every month, usually, with the new year, we decided maybe not right after the holiday. So here we are, second week of January, but we'll be diving back in Thursday, February 3rd, 6 p.m. Eastern time. As a reminder, our speaker series are always recorded. So if you have to hop off or you can't attend, you can always view in our Her library. Next time around in February, we will be chatting about a really interesting study. It's an integrative care study with our friends at IQVIA. They are a global provider of advanced analytics, technology solutions, and clinical research services. One of their researchers, who is also one of our Unite for Her community members, she will be joining us to discuss all of our findings, really solidifying and supporting all of the integrative work that we do. So definitely be on the lookout in February. Really interesting discussions, and I know I'm personally very excited to dive into a little bit more of those research findings. So Thursday, February 3rd, 6 p.m. Eastern Standard Time.
Terrific, Erin. Thank you. All right, are we ready to start with our first speaker? I'm going to let you go right in. I think so. Yeah, right in.
Dive right in. I know we're so excited to have Sue Friedman here. We've just begun our relationship with Sue, but I know we have so many exciting opportunities ahead. So to introduce Sue Friedman, she was a practicing small animal veterinarian when she was diagnosed with breast cancer at the age of 33. And afterwards, she learned she carried the BRCA2 mutation. After her diagnosis, she recognized gaps in the information and resources for people making medical decisions around hereditary cancer. After finishing her treatment, she founded Facing Our Risk of Cancer Empowered, FORCE, in 1999 to fill the information void for people facing hereditary cancer and help them advocate for themselves. As founder and executive director of the nonprofit FORCE, Sue has 22 years of experience assessing and addressing the unique needs of individuals and families affected by inherited mutations associated with hereditary cancers. So Sue Friedman, thank you so much for being here. We are ready and willing to learn, so take it away.
Well, thank you so much. I really appreciate that great introduction. And really thank you for inviting me to speak about a topic I'm really passionate about. I'm really not the expert here. My expertise is really in educating and helping people advocate for themselves, especially people going through cancer or cancer risk. And so really my goal is to kind of lay the groundwork so that the experts can come in and talk about this topic in more detail. So I'm going to share my screen. And put it in slideshow mode. And hopefully everyone can see my slides.
Perfect.
Great. So, again, this is really informal and I'm not the expert here, but we do have some great experts that will speak after me that will really provide more detail. Like Erin mentioned, I am associated with FORCE, Facing Our Risk of Cancer Empowered, and our focus is hereditary cancer and providing information and resources for people with inherited mutations that increase the risk for cancer. So my BRCA2 mutation, even though I didn't know about it, I was born with that mutation and it increased my risk for cancer. But one of the things that we hear from people all the time is this confusion about inherited mutations, things that lead to cancer risk and can cause cancer and be found in the tumor, versus things that developed uniquely in a tumor that can help guide treatment. So just really trying to lay the groundwork for understanding the two different types of tests in general and why those results matter and why it's important for you to understand what kind of test you had and what the results mean. And that quote up there that, was from a survey that we did. So this was a patient who had responded to our survey. They had breast cancer, just saying, like, I really didn't understand my test results. So hopefully we can help address that. And so it might seem weird that I'm going to start with a slide about health literacy, but it's a topic I'm passionate about. And the reason I bring it up is that in the past, the focus of health literacy was on the patient, the person. You had to be health literate. You had to be an expert, especially when you're diagnosed. As you may know, suddenly you have to be an expert in everything about your diagnosis. And, you do research. If you haven't had any scientific training, I was fortunate to be a veterinarian. So I had some scientific knowledge, but it really didn't translate as well as I would hope as, I was trying to navigate my own diagnosis. But there's a shift now into this idea of organizational health literacy and really society health literacy. This idea that all of us have to work together, and especially those of us who create information for people trying to make these decisions, that it's really up to us to make sure that we're making the information we're providing understandable to everyone. So I love that. This is a new shift, and hopefully you will reap the benefits of that as more organizations and more healthcare professionals try and be more health literate in a way where they're communicating so that people can understand. We do a lot of surveys and we've done several. This was one of the most recent ones, really trying to understand how familiar people are with some of the terms that are used with regard to personalized medicine and cancer risk and diagnosis and treatment. And what we find is that there's still a lot of jargon that is used that people don't really understand. And a lot of times you'll see these words showing up in clinical trials. Your doctor may use it. It may show up in pathology reports. And it just really tells us, again, how much better all of us need to do. And by us, I mean advocacy groups and scientists and researchers and healthcare professionals in making sure that the terms that we use are understandable and people know them. And so you can see from this slide, a lot of people know what a genetic testing is, or at least they feel fairly familiar with it, and a gene mutation. somewhat fewer people. So green is very familiar, blue is somewhat familiar. Fewer people are familiar with the idea of inherited mutation. Inherited means you were born with it. You inherit it from your mother or your father. In my case, I got my mutation from my father, actually. So it gets passed down through the generation. But germline mutation is another term for inherited mutation, but most people don't know what germline means. And when we ask them, they don't like the term because it sounds like a germ and an infection. Biomarker testing is another term that people aren't as familiar with as we would like. Acquired mutation and somatic mutations, these are changes in DNA that happen after you're born. So they're not inherited mutations. And you can see more people are familiar with the term acquired mutation than somatic mutation. So, again, these are just terminology and their jargon. But it's important. What terms we use really dictate how much people can understand what we're telling them about tests and their test results. And, in that same survey, we get a lot of write-ins. We want people to express themselves. And we hear over and over again, people saying, I don't understand the jargon. I didn't understand any of it. And this last one is something that we hear a lot. People talk about a tumor having a mutation versus a person having a mutation. And that's the difference between an inherited mutation and an acquired mutation. An inherited mutation being something you're born with, and an acquired one that can develop in a tumor. And that's confusing. So our experts will really help try and parse that out. But one of the benefits of us all speaking in a language that people can understand and speaking in the same language is that it makes sure that when we're talking to patients, when you guys are talking to your healthcare professionals, when you're talking to your family, that we're all on the same page and we all know what we're referring to. And so this little, graphic here is something we hear a lot. We will ask people, have you had genetic testing? And what they will say is, I had a test and it told me I didn't need chemotherapy. Well, that's a different test. That's actually, what we would call maybe a predictive test, and you'll hear a lot about that. But that's not the same thing as having genetic testing for an inherited mutation. And so that miscommunication and that the fact that a person may not understand what their test result told them can have far-reaching consequences, because then they may tell their relatives, I don't have an inherited mutation. I had genetic testing and it was negative. And they may not realize that they didn't really have a genetic test for an inherited mutation. They had a different test that gave different information. And now that information that they're passing on to their relatives may not be the information the relatives need to make their own decisions. So really, if we can all be on the same page and just make sure that we're speaking in the same language, then we can make sure that when we're communicating with each other, that we're talking about the same test and we know what our test results mean. So at least at Force, and there's a lot of different terms for some of these tests, but at least at Force, when we talk about a test looking for an inherited mutation, something people are born with, we call that a genetic test, or we'll say genetic testing for inherited cancer risk, or genetic testing for an inherited mutation. And that says we are talking about a test that's looking to see if you inherited a change in your DNA that increases your risk for a disease like cancer. And typically that means you inherited it from one of your parents and that you can pass that on to your children too. And this is important information. It's usually a blood or saliva test. And it can tell you information that can dictate, what some of the best treatments may be for you, but also, your risk for additional cancers and your relatives' risk for cancers as well. So that's important information. We talk about at Force, we like to use the term biomarker or tumor test when we're talking about everything else. Things that arose from a tumor are because of a tumor. So, these can be proteins, they can be receptors, they can be anything else that you're going to find in a tumor that can also tell you about treatment. It can give you information about your prognosis, and it can find targets identify targets that may make you qualify you for targeted therapy. So also very important, and you will hear more about that from the other speakers. And just a quick slide to show that like really all cancers happen because there are changes in your DNA. And if you look at sporadic cancers or cancers that aren't caused by an inherited mutation, you know, you get cell damage. That's from wear and tear and, you know, damage from the environment or smoking or other things that can lead to cancer. And over time you get a mutation, and sometimes your body can fix it and sometimes it can't. But then you get that second mutation and then the third mutation. And eventually you get so many mutations that the cells no longer are normal and it's no longer under control, and that can lead to cancer. Versus someone with an inherited mutation, that first step has already happened. They have that first mutation. So they're one step closer to cancer, but they don't have cancer yet. And if you look at the other mutations that happen along the way, that inherited mutation is still there in the cancer cell. So that's why sometimes you can test a tumor and find an inherited mutation there because it's in every cell. So again, I'm certainly not the expert in it, but just to help clarify that. So before I finish, I'm just going to say one thing, and there's something called Ask Me 3 that's this, you know, tool that tells people before you leave the doctor's office, ask these 3 questions. You know, what's my diagnosis? You know, what are you recommending, and what does that mean for me? Well, you know, we just came up with ask for testing, and this is 4 things when your doctor orders a lab test to ask. Just so that you can be on the same page, and make sure you get a copy of that lab report if you can, that lab result. What's the name of the test? What's it measuring? What were my results? And what does that mean for my medical decisions and options? So with that, I am going to just give you our contact information about FORCE, and then toss it back to Sue for the rest of the presentation. And thank you so much for your time.
Thank you, Sue. That was terrific. And just so everyone knows, when we have the recording that we put up on her library, we will have the slide deck as well. So that was a wonderful slide deck for me, very comprehensible to read and figure out, and just loved everything about it. Okay, we are moving on now. We have Danielle McKenna, and she is a board certified genetic counselor at the University of Pennsylvania's Abramson Cancer Center, and provides cancer risk assessment and genetic counseling services to individuals and families that have been affected by cancer. So Danielle, I'm going to put you front and center next. And let's see. Perfect.
You can see my slides, Sue.
Got them. Yeah. Yep. And we actually now see next slide and notes. So I don't know if you want to be in that presentation.
Is that better?
Same. There you go. You got it.
Oh, did I just change it?
Yeah, you changed it. It's perfect now.
Okay.
Thanks, Danielle.
So thank you so much, Sue, for laying the groundwork there. A lot of what I'm going to talk about in the beginning will be a little repetitive, but it is really confusing. So I think that it's helpful to repeat things. And I will just say that genetic testing is a huge umbrella term. It can mean lots of different things. And it's very easy to get confused when people just say genetic testing, you know, about what they're actually talking about. We see this happen with patients, providers. We see what Sue described happening all the time, which is you ask someone, have you ever had genetic testing? And they say, yep. And then they give you their Oncotype test, which is not actually the genetic testing in the classic form that you would think about it. So I'm hoping to go over kind of all the different nuances of what types of genetic testing are out there. But to kind of get started, again, a little bit repetitive from what Sue said, but just to kind of say it again, all cancer is genetic, but not all cancer is hereditary. And so what I mean by that is all cancers are going to have genetic mutations if you look at them, because that's actually what causes cancer to develop, is you have mutations in your cells that lead your cells to grow out of control And that's what a cancer actually is. But not all cancer is hereditary, meaning that not all cancer is caused by mutations that have actually been inherited from mom or dad. And so to take that a step further, if we think about the BRCA1 and BRCA2 genes, let's specifically talk about BRCA1. BRCA1 is a gene that actually everybody has. We all have BRCA1. We get one copy of BRCA1 from mom. We get one copy of BRCA2 from dad. And the main job of that gene is to protect you from developing cancer. That's its main job. And so if you look at this picture here, for sporadic cancers or non-genetic, non-hereditary cancers, if you think of most people starting out with 2 working copies of BRCA1 in all of their cells that are protecting them from developing cancer. As they go through life, they might accumulate some damage to one copy of their BRCA1 gene, but then they still have this backup BRCA1 gene that continues to protect them from cancer. And it's not until they continue to go through life and have something happen to the other copy of BRCA1, suddenly they don't have any functioning BRCA1 gene, and that's when a tumor can develop. So for most people who have sporadic cancers or non-hereditary cancers, we're seeing those cancers happening later in life in their 60s, 70s, 80s, because it takes multiple lifetime events for the cells to accumulate enough damage for a cancer to develop. Versus in hereditary cancers, those individuals are born with one copy already not working. So from the start, they're already down one copy of their BRCA1 gene. It only takes one other lifetime event, and we don't know what these lifetime events are really, for them to knock out the other copy of BRCA1. They've lost that BRCA1 gene function, and that's when a tumor can develop. So that's why the hereditary cancers we can often see at younger ages, 30s and 40s especially. But very similar to what Sue said, it's not as simple as that. So cancer really has multiple mutations that have to occur over time for a cancer to develop. And why this is important to know is that if you have genetic testing of your tumor, there will be mutations. Absolutely, 100% we're going to find them, because that is how a cancer develops. And so the question really becomes, are these acquired mutations or are these inherited mutations? I'm going to try and keep talking about what the difference are between those two things. So germline mutations and inherited, think about those as the same exact thing. If anybody says germline, you can just swap out inherited for that word. And so these, again, are mutations that you can identify either blood or a saliva test. And then these are mutations that you inherited from mom or dad and you could pass on to your child. Somatic mutations you identify by looking at the actual tumor itself. It is not necessarily representative of what you are born with, and there's usually no risk of passing down a mutation if it's truly only in your tumor, but there's some overlap. So let me go to this slide really quick. So there's some overlap. So if you have an inherited mutation in BRCA1, for example, we will probably find it in your tumor because it's in all of your cells from the day that you're born. So if you have an inherited mutation, we're probably going to see it in your tumor. Versus if you have a mutation identified on your tumor test, it is more likely to have just occurred sporadically over time, randomly, not inherited. But it's possible that it was inherited. And so if you find a BRCA mutation in your tumor, what typically happens is your doctor then refers you to have germline testing to determine, where did this mutation come from? Is it sporadic or did you inherit it? So the only way to know for sure is to have blood or saliva tests. That's the only way to know for sure if your BRCA mutation was inherited from one of your parents and if there's a risk of passing it down. Hopefully that makes sense. A metaphor that I've often heard used to describe the difference between germline and somatic, if you think of germline, again, inherited testing, if you think of it as like a blueprint, it's the instruction manual, it never changes. it's going to stay the same over time. Versus somatic testing can represent changes that occur over time. So cosmetic changes. If you change the color of the house, you're not always going to see that in the blueprint, but it's still there. So I've heard people use that metaphor. Sometimes it's helpful for people, sometimes it's not. But just to really kind of drive home that they're very different types of tests and they can mean really different things. And the goal of those two tests are very different. And Sue touched on this as well. So the goal of somatic testing or tumor testing is to identify targetable mutations so that they can use that to make treatment decisions. Sometimes it helps them evaluate the prognosis of an individual. And sometimes it can actually aid in the diagnosis of what type of cancer it is, because certain types of cancers are more likely to have certain mutations. So there's a couple of different uses for somatic testing, but primarily it's used for treatment decisions. And who usually orders somatic testing are oncologists, sometimes radiation oncologists, sometimes surgeons, but it's your cancer treating doctors who are going to be ordering the somatic testing. Versus germline testing or inherited testing, that is looking to see if there was a hereditary explanation for why you developed this cancer, and could that be useful for you going forward, and could that be useful for family members going forward. We can use that information to hopefully prevent any other family members developing cancer. And who typically orders the germline testing? I'd like to say it's always genetic counselors, but it's not always genetic counselors. Sometimes it's geneticists, sometimes it's oncologists, sometimes it's gynecologists, even PCPs are doing it. But it is very beneficial to meet with a genetic counselor when you're doing germline testing, because they can really help you understand the implications of this test and what it would mean if you were to come back positive. Now, to get a little bit more specific, what are the different types of genetic testing that we can see in breast cancer? So if we're thinking about germline, again, inherited testing, BRCA1 and 2 testing is the testing that people are most familiar with. They've heard about that before. They want the BRCA test. That's a germline test. We also are more frequently now in 2022 doing panel testing, which is looking at BRCA1 and 2, plus a handful of other genes that have been associated with hereditary causes of breast cancer. That is most often what we do now in 2022. And I will touch on who should have this testing and who needs updated testing. I'll touch on that. So those are examples of inherited testing that's done via blood or saliva versus examples of somatic testing or tumor testing. They can do somatic sequencing of a tumor when they're, again, looking for what mutations cause this tumor to develop. Some examples of companies that do that test that you might hear your doctors saying are Foundation One testing, Caris testing. Penn has their own test, so they do a lot of in-house testing. So if you're going to a larger academic center, they might just do it in-house. But the goal of that testing is to figure out which chemotherapy is going to be most effective in treating this individual's cancer. Liquid biopsies is also something you might hear your doctors talk about. This is more common in people who have more advanced cancer, because people who have more advanced cancers, they can actually pick up cancer cells that are being shed into your bloodstream. And so that is another way of doing sequencing of the cancer to figure out what targeted therapy is going to make most sense for that person. And it's less invasive, right? Because they can do it on a blood sample versus having to have tumor or having to do like an additional biopsy, for example. So that is another term you might hear of as genetic testing. It's done on the blood, which gets confusing because that's what we typically do for the inherited testing is blood. But there are some tests. Guardant is the main company who offers liquid biopsies. And again, this is mostly in people who have advanced cancers, because if you have early stage cancers, it's less likely that your tumor is shedding into your bloodstream. So that's really more of an advanced cancer test that we can see being done in breast cancer. And then the third type of somatic or tumor test that you can hear about with breast cancer is Oncotype testing. You're going to hear way more about this after me. But the goal is slightly different. It's a different way of doing genetic testing, and the goal is different because the goal here is to determine if chemotherapy is indicated for certain women versus which chemotherapy. So the goal is a little bit different, and there is no overlap between germline testing and Oncotype testing. So there's no situation in which someone would bring me an Oncotype test and say, they told me I needed to get genetic testing based off of this Oncotype test. There's really no overlap. Think of those as just very different types of tests. Versus somatic sequencing, that's why I put this arrow there, sorry. Somatic sequencing, there can be overlap, right? Because if they find a BRCA mutation in your tumor, then they're going to refer you back to have the inherited or germline testing. So there is overlap with the sequencing type test, but there's no overlap with the Oncotype test. And then if we're thinking about different genetic testing options in ovarian cancer, the germline or inherited options are very similar. So BRCA1 and 2 testing or panel testing. I put slightly different genes here because there's slightly different genes associated with ovarian risk versus breast risk. And then in terms of the tumor testing that we can see being done in ovarian cancer, again, we can see somatic sequencing of a tumor, Foundation 1, Caris, all looking for targeted therapy options. We can see liquid biopsies, so the same type of testing I mentioned before, but it's less common that I see that being ordered in ovarian cancer. I see it more often being ordered in breast cancer. I don't know if that's a Penn specific thing, but I don't see too many liquid biopsies being done with ovarian cancer, but you could. And then the third and kind of more unique test to ovarian cancer that is available is something called Homologous Recombination Deficiency, which is a mouthful. So HRD is how most people talk about it. HRD testing of a tumor. Examples of some labs that do this that you might hear your doctors throwing around: Myriad Genetics, Foundation 1, and Caris. So similar labs that do somatic testing. And what's confusing is Myriad Genetics also does the inherited testing. So again, it's really easy to get this all confused. And it's really important to know which test that you had, especially for familial implications, if you're trying to figure out what it means for family members. Now, the HRD test is almost an evaluation of BRCA-ness in a tumor. So even tumors that don't have BRCA1 and 2 mutations can have very similar signatures, is kind of the term that they use, or they can have very similar feels, if you will. And the reason that that's important is because even if it doesn't have a BRCA mutation, if it has HRD, it's probably going to react to the same drugs that we use to target tumors that have BRCA1 and 2 mutations. So specifically with ovarian cancer, if your somatic sequencing does not find a mutation in BRCA1 and 2, they often then look at HRD before they make a final decision about whether or not they're going to prescribe any targeted therapies related to a BRCA mutation. And I will talk about what those are in just a second. But another question that we get is who should have the germline or inherited test? This is not an all-inclusive list. It's kind of just like the most obvious ones that should be having genetic testing. If you don't fit this list, but you're interested, certainly talk to your providers about whether or not they think it's a good idea for you to have genetic testing. And some of this is relatively new information. So if you were diagnosed a couple years ago, this might be an update to what you were told. So all ovarian cancer patients in 2022 should have genetic testing. That is now a new national guideline. So if you had ovarian cancer 5 years ago and you didn't have genetic testing, come back and get it. All breast cancer patients diagnosed under 50 should have genetic testing. All triple negative breast cancer patients, especially the triple negative breast cancer patients who are diagnosed under 60, those are the ones who are likely to have, or more likely to have BRCA mutations versus people diagnosed over 60. If you have breast cancer and you have Ashkenazi Jewish or Eastern European Jewish background, you should have genetic testing. And that's because we know that BRCA1 and 2 mutations are more common in individuals of Ashkenazi Jewish background. All male breast cancer patients should have genetic testing because they have a pretty high rate of having an inherited cause of that type of cancer. In all metastatic breast cancer patients, this is a fairly new update, should have genetic testing, and that's mostly due to treatment implications, which I'll get to in just a second. If you don't meet any of those criteria, but you have breast cancer and you have a family history of breast cancer and or pancreatic cancer and or ovarian cancer, you're also probably a good candidate for genetic testing because those are all the cancer types that we can see more commonly in families that have BRCA1 and 2 mutations. And then who should have updated germline testing? So if you had genetic testing prior to 2013 and it was negative, come back. It's time for updated testing because prior to 2013, we weren't doing panel testing. So you probably were only tested for BRCA1 and BRCA2. And we want to look at those other breast cancer genes to see if we can figure out a hereditary explanation for your history. If you only had BRCA1 and 2 testing and it was negative, like I said, come back. There's updated testing to offer you. If you're not sure what you had, contact your doctor, see if they can look at your report and see if you need updated testing, or try and reach out to a genetic counselor who could help determine if you're eligible for updated testing. If you Google find a genetic counselor, it'll take you to a website where you can put in your zip code and it'll tell you the nearest genetic counselor for you to reach out to. But there has been a lot of changes to genetic testing. So if it's been a while and you have this family history, we can't figure out what's going on, come on back to see a genetic counselor because there's probably more testing we can offer you. And then what do we do if we find a positive genetic test result? And this is mostly in the context of if we find an inherited BRCA1 or 2 mutation, for example. So if we find an inherited BRCA1 or 2 mutation, there are national guidelines about recommendations for screening and prevention. So how to reduce the chance of you getting another cancer later in life, or how to reduce any cancers from developing in your family members if they have the same mutation as you. If you have an inherited mutation, it can also impact treatment for patients who have an associated cancer type. And Parp inhibitors are the key here with breast and ovarian cancer, and I'll kind of explain how they work. However, Parp inhibitors can be prescribed if you have an inherited BRCA1 or 2 mutation, or if you have a somatic BRCA1 or 2 mutation, because if there's any BRCA mutations anywhere in your cells, you have a better chance of responding to a Parp inhibitor. And in ovarian cancer patients, even if your germline BRCA is negative and your somatic BRCA1 and 2 is negative, if your tumor looks like it has that HRD signature, you are also eligible for Parp inhibitors. So there's kind of 3 tests that need to be done in newly diagnosed ovarian cancer patients to determine if you're eligible for Parp inhibitors. And one of the reasons that Parp inhibitors, there's so much buzz around it is, first of all, it's a pill. It's not an infusion. So it's a pill that people typically take 2 times a day for 1 to 5 years, depending on, what your oncologist tells you. But it's a pill and it has a lot less side effects associated with it than the typical infusion that we can think about. And it's extremely, extremely targeted. So it's really only focusing on people who have mutations in BRCA1 and 2, and it's specifically targeting that. And so how I try and think about how Parp inhibitors actually work is, if you think about a cancer cell, in order for cancer to continue to grow, it has to continue to divide over time. And there's 2 ways for cells that, well, let me say, during cell division, mistakes are going to happen. So when your cells are dividing, mistakes happen. And there's 2 ways that your cancer cells can fix those mistakes so that they can continue to grow. One is dependent on having functional BRCA1 and 2 genes, and the other is dependent on having functional Parp. So people who have mutations in BRCA1 or 2, whether or not it's inherited or somatic, that one mechanism of repairing your cells is not working. So your cells can't use that mechanism to continue to grow. So they have to rely on the Parp inhibitor or on the Parp proteins. So if you take a Parp inhibitor and you knock out the Parp proteins, suddenly your cancer cells have no way to replicate and continue to grow. And so they die. That's called cell death or apoptosis. And that's what we want to happen, right? And it doesn't impact your healthy cells because your healthy cells should have some function of BRCA1 and 2. So it really is only targeting your cancer cells that no longer have functioning BRCA genes. And therefore, that's why we don't see a lot of other side effects because it's so targeted just to the cancer and to the individuals who have mutations in BRCA1 or 2. So that's why PARP inhibitors work so well for that specific group of people. And that's all I have. So hopefully that made sense, but I'm happy to answer any questions either now or later.
Danielle, I did see a question come through earlier on in your presentation. Someone asked, do you get the same type of cancer or any type of cancer if it is an inherited mutation?
Do you get the same type of cancer?
Yeah, do you get the same type? You know, if it's an inherited, will you get the same type of cancer that you've inherited from that family member, or could you get any type of cancer?
It's not always the same as your relative. So you could have one family member that has like an estrogen positive breast cancer, and then one family member who has an estrogen negative or a triple negative breast cancer, for example. So you can have different cancer types occurring in the same family, even if they have the same mutation.
Erin, there was one more there. Did you see that one?
Yeah. Oh, that's a really interesting. Mother had breast cancer. Paternal grandmother had breast cancer. This person had ovarian, yet no mutations. How is that possible?
Yeah, so that's a family that we would expect to find something inherited, but we don't always find it, even in the families that really look like it. So Trish, if it's been a while since you had genetic testing, please come back. If you've had genetic testing recently, please continue to ask your providers, you know, over time, every year, any new genetic testing, because hopefully we'll eventually figure that out. But it's frustrating when we don't.
There was one here, Danielle, that came to me directly, and it might have been covered, but I thought I would just say it again just to hear you. This might be covered, but I'm wondering if primary tumors are tested for somatic testing. I had germline testing, but have heard that somatic testing would only be done if there is a reoccurrence. I had no germline mutation.
That's a great question. Yeah, so often somatic testing is only done in more advanced cases when they're going to be prescribing chemotherapy. So if you had an early stage cancer, they probably didn't send for the somatic testing because they wouldn't be worried about prescribing chemotherapy.
And then this is just a personal question from me, Danielle. So to be clear, I was diagnosed in 2004, 17 years ago, had the genetic testing. I was 39. I should come back because things have changed so much. Is that what you're saying?
You should come back.
Okay.
Yeah.
Okay.
And then I do see this question about P10. So P10 is a gene that can be inherited or can be somatic. It's more likely to be somatic because it's a pretty rare condition to inherit. But there are people who have inherited P10 mutations, and what we usually see in those families are breast cancer, uterine cancer, thyroid cancer, and then a lot of benign tumors in the same body parts. So like thyroid goiters, fibrocystic breast, uterine fibroids, but it's usually very, very pronounced, meaning there's like a lot of benign tumors that their physicians usually pick up on, and they actually tend to have larger head sizes. So that's something that often also triggers testing for PTEN in the inherited setting is when you're a kid and your doctor is measuring your head all the time to make sure that you're, on track. If your head is perceived to be larger, they might then start asking other questions about your family history. Like, do you have this family history of cancer and benign tumors? But yes, it can be inherited. Pretty rare to have an inherited PTEN mutation though.
Danielle, you see that last one?
Are PARP inhibitors used
PARP.
prophylactically? Not yet. It's an excellent question. I think a lot of people are really curious about that. Like, if you have an inherited BRCA1 or 2 mutation, could you take PARP inhibitors every 5 years to like stave off any developing cancer cells? People are really interested in that, but we don't have an answer for that yet. That's something that is being investigated.
Okay. 2 more here. Breast cancer in mom and in an aunt on both sides, no mutations in panel in 2017. Diagnosed at 48 and triple negative. Are there new mutations to test for since 2017? My history looks like I should have had a mutation. Thoughts?
There's probably not new mutations since 2017. There hasn't been too many changes in gene discovery since 2017. There's one thing that's changed recently from a technological standpoint. And so most genetic testing in the past was only looking at your DNA. Some labs now will look at DNA and RNA at the same time, which is thought to pick up a very, very small percent of mutations in genes that were missed previously, like less than 1%. So I would say, Beth, that there's a less than 1% chance that we missed something, but if you really want to come back and investigate that, you could ask specifically for RNA testing. And we just don't know which families are the ones that have the mutations that were missed with DNA. So it's worth asking, especially with that history. That's pretty suspicious. So I would keep asking.
Okay. I think what I'm going to let you do, just because we're mindful of time, Danielle, could you use the chat and answer a couple of the ones that were coming in? And then Erin, how about if we introduce our next speaker, and then we will have a final Q&A. So that way, if people have to get off, later, 7 o'clock or a little bit after, they can. If they want to stay on, we're happy to stay on. All right, Erin, I'll turn it to you.
Perfect. Thank you. Yeah, so many great questions coming through, but we do want to get into our third speaker. So I'll introduce Cece. So Cece Lynch Hammond is a senior medical science liaison with Exact Sciences. She received her Bachelor of Science in Nursing from Marshall University in Huntington, West Virginia, and Master of Science in Nursing from Benedictine University in Lisle, Illinois. At Exact Sciences, she is part of the Precision Oncology Medical Affairs team, providing educational and clinical support in a variety of cancer-related topics with a special passion for breast cancer education. Cece, thank you so much for being here.
Thank you, Erin, and thanks everyone for the warm welcome. I'm going to share my screen and my slideshow. So again, thank you for the warm introduction. I am an employee of Exact Sciences, and Exact Sciences is a supporter of this webinar series. And so I'll be presenting some content today that discusses some of the genomic tests that Exact Sciences offers, but I really will not be addressing any specific clinical or diagnostic or treatment advice. For that, I would refer anyone back to their individual clinician. However, we do have a very comprehensive website that's here on the screen. It's oncotypeiq.com. And there's a section for healthcare providers and also a section for patients and their caregivers, and several videos and a lot of information about all of the products that Exact Sciences has to offer. As a breast cancer survivor myself, I'm very privileged to be here tonight. I was diagnosed over 25 years ago, and none of these tests were really available at that time. So my treatment was based on just basic biomarkers done in the pathology lab. So we've really made a lot of advances since then. And we just heard a really excellent discussion on genetic testing and genetics. But I'm going to address the broader topic of genomics and try to blend how genomics and genetics are the same, but have similarities but differences. And I'll also share some of the information that 2 of our tests can provide in both early stage cancers and late stage cancers. And weave into this ways that you as a patient or a patient's family can be confident in the results that you're getting from not only the genomic tests that my company provides, but other companies, because there are many, many different companies providing these tests, and how you can be confident in the results and the recommendations that you're receiving as a patient. So when we think about genomics obviously is looking at genes, but it looks at genes in a different way. Instead of looking at genes to provide a risk of developing disease, genomics looks at how genes function within the individual patient's tumor or within the organism at large. So genomic testing is offered after a diagnosis of cancer, and it's used to help predict the response to certain therapies and be prognostic on whether cancer is likely to come back or spread after the initial treatment that is given. So it can be thought of as biomarker testing or tumor testing. Genomic tests can be performed on tissues, but as we've heard in the presentation up to now, there are advances now in testing on blood. So genomic testing is an ever-growing field of science, just as genetic testing is. So why might a clinician order a genomic test, say, versus a genetic test? So a clinician would order a genomic test if it helps individualize the treatment for the patient. Genomic testing can help look at a variety of genes within the tumor tissue to help determine the underlying biology and how patients might respond to specific treatments. So it can help identify targeted therapies that may be specific to that person's individual type of cancer. Another area that's important and helpful in ordering a genomic test is for patients who have exhausted their traditional therapies. Their cancer is metastasized, it's progressing. Maybe there's a clinical trial looking at a newer agent or a new treatment that's specifically designed for that person's specific biology. So genomic testing is often used as an inclusion criteria for many clinical trials. Each genomic test that's out there on the market has certain criteria for patients to be able to get it. They're often based on how the test was designed, what the test is really designed to show, and we know not all breast cancers are the same. So when a patient has a diagnosis of early breast cancer, the surgeon either takes a core biopsy or perhaps it's a surgical specimen that goes down to the pathology lab. Certain tests are performed in the hospital pathology lab as a matter of course to determine the type of breast cancer and certain basic biomarkers, if you will, about that cancer. There are 3 that are standard of care that when you get your pathology report early on in your diagnosis, you'll know, is your cancer estrogen receptor positive or negative? Does it overexpress HER2, another gene? Those biomarkers are considered predictive biomarkers because there are targeted drugs. There are drugs that are developed to target cancers that express those biomarkers. And often treatment decisions are made on those. But with the advent of genomic testing with broader panels, now we're able to provide more information than just those basic initial tumor biomarkers that a patient receives on their initial diagnosis.
Cece, oh, there you go. I didn't know if your slides were going. I wanted to make sure they were turning.
Yeah, so I was just a little slow on the change over there.
All good.
I want to talk a little bit about a biomarker that our company makes, Exact Sciences. We were formerly known as Genomic Health. Some of you may remember that. It's the breast cancer recurrence score. It was referenced earlier in the talk as the Oncotype DX test. Right now, I want you to just focus on that first bullet point, because in the year 2000, the National Institutes of Health put out a consensus statement recommending chemotherapy for the majority of women who were diagnosed with localized breast cancer. Early stage, regardless of lymph node status, positive or negative, menopausal, even regardless of their hormone receptor status. At that time, the best evidence we had was that everybody should be offered chemotherapy. We knew, physicians knew at that time, they were overtreating a majority of women who were not likely to benefit or need chemotherapy. But there was really no way to determine that based on the evidence at hand at that time. So since then, genomic panels such as the breast cancer Oncotype DX recurrence score have been developed to provide further information to determine whether a patient's cancer is likely to come back if they just get their endocrine therapy alone, or if they're likely to have a tumor biology that's likely to respond to chemotherapy. So I'll come back to these other 2 points in a minute. So what is the 21 gene recurrence score? It's a genomic test. It looks at the activity of 16 tumor-related genes, and the reason it's called the 21 gene score is there are 5 reference genes that are always run in conjunction with the cancer genes to make sure that the result that a physician gets on your tumor specimen is actually accurate and represents what's really going on in that cancer tumor specimen. Patients are eligible for the test if they're recently diagnosed with invasive breast cancer and medically eligible for chemotherapy, because as was mentioned before, this is a test that can determine whether a patient is likely to respond to chemotherapy. And if for some reason a patient's very frail or not eligible to receive chemotherapy, perhaps the recurrence score is not going to be ordered for that particular patient. And so then you can see that the cancer is earlier stage, it hasn't spread to other organs, it expresses the estrogen receptor, so it's ER positive and HER2 negative. So that's the arena in which the 21 gene recurrence score was tested and validated. So going back to this slide, looking at, okay, how do we know this? The recurrence score gives a score of 0 to 100. And we know from early data in the early 2000s that patients who had a low score were most likely to respond really well to their hormonal treatment, which at that time was just tamoxifen. Now there's another class of drugs called aromatase inhibitors. But patients with low recurrence scores did very well with estrogen therapy alone. But as the score went up, the higher the score, the more likely the patient was to benefit from chemotherapy. And we knew that in patients who had both node-negative breast cancer and node-positive. Since then, 2 major trials have been reported. The TAILOR-X trial and the Responder trials have reported to support that initial thinking that was developed early on in the recurrence scores development. So TAILOR-X, some people may have heard of it. It was a 10,000 woman trial that assigned patients treatment based on their recurrence score number. And it was able to look at that intermediate group, which some people have mentioned to me, oh yes, I had one and it was low, intermediate, and high, and we don't know what those buckets are. Those buckets are relatively gone now because we've got more precise data from TAILOR-X and Responder looking at what the individual score might represent for a patient's prognosis and prediction for chemotherapy benefit. So we have this from TAILOR-X in women who have node-negative breast cancer, and the Responder trial was a corresponding trial of 5,000 women who had 1 to 3 positive lymph nodes. And based on data that have been published, the recurrence score now can identify a majority of hormone receptor positive, HER2 negative breast cancer patients that can safely forego chemotherapy. So the overtreatment conundrum that really was caused back in 2000 now has become a lot more manageable, and we can use these genomic tests to just decide which patients are most likely to respond to chemotherapy and those who can forego. And to the third bullet, how can you trust the data that people are talking about here? I heard guidelines mentioned in the previous presentations. There are several guideline groups that exist to help clinicians interpret and understand new data that comes out, whether it's on a genomic or a genetic test or a new drug or targeted treatment. The NCCN is a consortium of 31 major cancer institutions. It's a nonprofit organization that has created this a guideline committee. So as new data comes out, as the TAILORx data is published and data on clinical trials for certain drugs, they have committees that actually look at this information, they vet it. Is it accurate? Does it make sense? Is it clinically meaningful to patients who are diagnosed with cancer? So they create guidelines and they update them periodically. There's another group called ASCO, the American Society of Clinical Oncology. They also have guidelines. So when you see a test or a drug that's included in these guidelines and in the genetic testing arena as well, you can be assured that experts have looked at these data and determined them to be accurate. So for the NCCN guidelines, the Oncotype DX test has been identified as the only genomic assay that can predict adjuvant chemotherapy benefit, and it's recognized as a preferred test for patients with node-negative disease and postmenopausal women with 1 to 3 positive nodes who fit this criteria of HER2 hormone receptor positive, HER2 negative early breast cancer. So what I thought I would do is share an example of an Oncotype breast report in case someone has never seen one before. So this is a patient who had node-negative, hormone receptor positive, HER2 negative early breast cancer, who had a recurrent score assay performed. And you can see here are patient characteristics, because cancer evaluation and treatment is not performed in a vacuum. So patient characteristics do come into play, age being one of them. This patient happens to be postmenopausal. She has a tumor grade of 2, and when we're talking about that initial pathology report that comes back with the ER/PR and HER2, they'll also provide what the tumor grade is, and grade means just how abnormal does that tumor specimen look compared to a normal specimen, and tumor size comes into play. So this particular patient had a score of 15. The data that the recurrent score report can provide here is, we know based on the data from TAILORx, that 10,000 patient clinical trial I mentioned, that patients who have a recurrent score of 15 had about a 4% risk of distant recurrence of their breast cancer coming back in a distant site at 9 years of about 4%. And in those women who have this score of 15, the potential for chemotherapy benefit was less than 1%. Now, given age as being a caveat, and it's the same with the node positive responder data as well, for older patients, it's very clear that a score of 0 to 25 in the TAILORx population saw no benefit from chemotherapy. If patients were younger, and in the case of responder and node positive, they're premenopausal versus postmenopausal, there are caveats. But the end result is that these large clinical trials have confirmed that using a genomic assay such as the Oncotype DX recurrent score can help determine what the underlying biology is of an individual patient's cancer and what the likelihood of them responding to hormonal therapy alone or with the addition of chemotherapy added to their standard of care. And so moving on from the early stage setting, how can genomic profiling help in the advanced setting or metastatic? And we've talked a little bit about this. There's a little bit of overlap here between genetics and genomics more in this space, but I like to share the information on this slide. So there is a project, and there were more than one, but it was called the Cancer Genome Atlas Project. And it was launched by the National Institutes of Health in 2006. And its goal was to map the genome of cancer. So they wanted to understand all these genomic and genetic alterations that underlie all major cancers, not just breast cancer. So it's comprehensive. There are many data sets and studies that are using the data that's been generated from this huge undertaking, the TCGA. And what they're finding is that there are gene variants that can be identified that are linked to response with certain targeted therapies. So when a patient has developed metastatic disease and their current treatments are not working, these larger panels can be applied and used to see if there's maybe a genetic alteration in a single gene that might have a targeted therapy. And I know this is a really busy slide, but Exact Sciences has one of these panels. It's called Oncotype Map Pan Cancer Tissue Test. It looks at what's called a comprehensive NGS panel and targeted IHC panel. An IHC is typically what the pathology lab at the hospital uses. It's a way to stain and look at the expression of certain markers in a cancer cell. Next generation sequencing is a technology, and it's very advanced and it's growing and developing every day, but it's the ability to take a specimen from a tumor or even blood and break it down into its individual gene components and run it on a very advanced machine to look to see if there are alterations or mutations in a variety of genes. The different panels look at different genes. Some panels have more, some panels have less. There are a lot of data that are generated from these large NGS panels. And it's not always the case that there will be a gene that's targetable with a drug. So when you get a report back, say from Oncotype Map, there will be a page that says, this particular tumor has this alteration. And because of this, there is a specific targeted therapy for that alteration. But that's not always the case because there's not always a mutation or an alteration found. And if there is, there may not be a targeted therapy. But the other piece that these tests can provide are clinical trial options. So even though there's not a approved therapy right now, there may be a test that's in development that the patient could qualify for a clinical trial. So again, the genomic panels not only help drive treatment now, but they may be able to indicate a clinical trial or a research study that a patient could qualify for. And then finally, I'll just close with this slide. So this is our family, our suite of precision oncology tests right now. And we are developing more every day, but we've talked about the Oncotype DX breast recurrence score, which can help determine prognosis and prediction of chemotherapy benefit. We have other assays as well in different tumor types. We have our prostate score, which helps determine pathology for patients with early stage prostate cancer. There's the Oncotype DX breast DCIS score, which looks at patients who are treated with for DCIS and then what the potential benefit of radiation therapy would be for those patients. We have a current score for colon cancer. And then in our late stage setting, we have an additional test for prostate cancer to help drive treatment decision-making. And finally, our Oncotype Map, which is our large pan cancer tissue panel. So I will stop there and say thank you and address any questions that I can.
Thank you, Cece.
That's
We
all.
actually do have one here in the chat, and it's from Trish. She's wondering if you're developing, or are you in development of a recurrent score test for ovarian cancer patients?
We are not in, we do not have a specific recurrent score in development for ovarian cancer. However, our our Oncotype map is available for advanced solid tumors in general. So a patient who may have advanced ovarian cancer or metastatic disease would be a candidate for our Oncotype map testing. So not really in the early stage, which would be nice because it's really hard to pick up early stage ovarian cancer, but more in the advanced setting right now. And we are in development looking at some screening tools that may be able to pick up early cancers, but those are not really ready for prime time right now.
Okay. There was another question that came in from Amy, and that was, is there a somatic test for triple negative breast cancer?
Well, I'll take a stab at this. For triple negative test cancer, it's really based on those initial biomarkers that are performed early on in the pathology lab. So looking at the ER expression and the PR expression and the HER2 expression in the original pathology report. That's generally how triple negative breast cancer is diagnosed. I don't know if that answers the question. Danielle, you may have something else that you wanted to add.
I would just add that most triple negative breast cancers require chemotherapy to treat their cancer. And so that's why they don't usually order Oncotype testing in triple negative, because they've already decided that they're going to do chemotherapy just based off of the fact that it's triple negative.
Right. And there are really no markers to treat, no identified markers. Mm-hmm. Thank you.
So Erin, I think I'm going to put all three of our speakers front and center. And that was fantastic. Such a wealth of information. I learned so much. I can't thank you all enough. I know you've been so active in our chat, and we're going to make sure we post the chat as well as the presentations, the decks, and of course this recording. With that being said, we are happy to stay on for a little bit if you have some more questions. So if you wanted to put a couple on the chat, our speakers, if you feel like you have a tight schedule, we absolutely understand and you can go. But if you want to hang out for a little bit, happy to have some more questions in the chat. And you guys are all getting a lot of love for these presentations. Thank you.
If I could just say one closing thing and just really encourage people to get your test results. If you don't understand your test results, ask your doctor, ask your healthcare professional, keep asking questions about it, get them in front of you. Even if they seem complicated, try and, get someone and one of your healthcare team to explain what they mean so that you understand the test and what it means for you.
I love that. So much positivity coming from the chat. Yeah.
Yeah. Good. All right. Well, Erin, I think I'll let you wrap it up then. Looks like you guys were busy in that chat. Thank you. We really appreciate you getting in there and just getting right down to it and answering those individual questions.
Yeah, so much engagement. I think that just speaks to the importance of this discussion and having experts like the three of you here available, just sharing your knowledge and, sharing, that we have to be advocates for ourselves. So we appreciate you being here. We appreciate your time. Hopefully we will have you back with us in the future to continue imparting your education and knowledge. So again, thank you so much for being with us and spending your Thursday evening with us. Just as a reminder, again, we want to really give a sincere thanks to our partners, our presenting sponsor, Merck, as well as our supporting sponsor, Exact Sciences. They really help us continue these educational series moving forward and continue to bring important topics like genetic testing and tumor marker testing, so we can have these thoughtful discussions. So we're very grateful to them. And then as always, we have these every month. So hopefully you will join us for our next speaker series. Thursday, February 3rd at 6 p.m. Eastern time, we'll be looking at some really interesting data from a recent study looking at integrative treatments and how they affect overall wellness.